And joining us now to talk about your health is Dr. Peter Olivieri, Director of Interventional Pulmonology at the University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you for joining us. It is Lung Cancer Awareness Month. What do you want our viewers to be aware of?
Well, we want them to know that lung cancer is a very important issue that we're faced with in our country. It's unfortunately the leading cause of cancer death worldwide, and is something that if people don't know that it can be asymptomatic at an early stage, we want them to know that as well.
I did not know that. So at what stage does it typically become symptomatic? And I mean, you think of somebody coughing a lot. Is that the common symptom?
It can be, yeah. Unfortunately, it often doesn't present with symptoms until it's at an advanced stage, often stage 3 or 4. And cough can definitely be one of the symptoms.
You definitely want to see people at stage 1 as opposed to stage 4.
Absolutely. Yeah, that's where we have the opportunity to cure them. So we want them to be diagnosed as early as possible. But there's an inherent challenge there when they don't have symptoms.
So what's the solution? What are you working on there?
Well, one thing is what we call lung cancer screening. Just like other cancers, patients that have risk factors for lung cancer do qualify for screening. And in this case, it comes in the form of a CAT scan, which is typically done once per year in patients that have risk factors. So that's something that is very important, but is at the moment, unfortunately, underutilized.
Needs to be a CAT scan, a CT scan, as opposed to an inexpensive old-fashioned chest X-ray.
Correct. Yeah, an X-ray will not be adequate to screen for lung cancer.
And a lot of times you wind up catching cases, hopefully early, because the CT was ordered for some other purpose.
That's absolutely true. We call those incidental pulmonary nodules. We use the term nodule to describe small spots in the lung, and most of these do not represent lung cancer. Most of them are benign, but a small percentage of them do represent early stage lung cancer. And by far, the most common way that early lung cancers are detected is through this incidental nodules, as opposed to patients that undergo screening. The problem here is that historically, patients that have incidental nodules may not get adequate follow-up, and these may slip through the cracks. Patients may be either unaware that they have a nodule, or they may forget due to the circumstances, as you said, because the CT scans are being done for another reason. For example, if they're in the emergency department after a motor vehicle accident, they may have other things that are distractors.
And that's something you're also working on. Once the issues with, say, it was a motor vehicle accident, are resolved, somebody needs to follow up and remind the individual, or tell them in the first place that we need to follow up on the lung issue.
Absolutely. So our hospital, Baltimore Washington Medical Center, part of the University of Maryland, we're developing an incidental nodule program. And this is something that a lot of other hospitals are going to need to do as well. In fact, we recently completed a pilot study that will lay the stage for our program. And what we found is that about a quarter of patients, about 1 out of 4 that have a CT scan of the chest done in the emergency department, actually have at least one pulmonary nodule. But unfortunately, only about 50% or half of them are getting the adequate follow-up that they need. So our hope is that by creating a program which will act as a safety net, we'll identify these patients in real time and contact them after their emergency department visit to connect them to appropriate care.
If that many people have nodules, does that hopefully mean that they're not all cancerous, that it can be something else?
Yes, the vast majority of these are not going to be cancer. The challenge is sifting through all of that to identify the ones that are, so that we can provide an opportunity for those patients to be diagnosed early.
Well, tell me about the new technology. We always like new technology. It's a robotic device. And what does it do? How does it improve your ability to biopsy the nodules?
At our center and at many centers now, robotic bronchoscopy is being used as the primary modality to perform lung biopsies. So some patients who have a lung nodule that looks suspicious need a biopsy procedure where a small sample is taken so that we can definitively determine whether or not their nodule represents cancer. What the robotic technology brings is a few things. For one, the instruments are much smaller than the traditional instruments that we use, and this allows us to reach parts of the lung that we simply couldn't access before. In addition, they're also extremely stable. So by staying very, very still, it allows the operator to do other things at the same time, such as using imaging modalities like ultrasound, X-ray, and CAT scan during the procedure, which helps them precisely localize very, very small nodules so that we can take accurate samples.
And if you do find out that there's a problem, in addition to confirming that, the biopsy also gives you information about how best to treat it. Is that right?
That is correct. So in addition to providing a diagnosis, our goal is to also stage patients at the same time. And we do this by taking biopsies of one or more lymph nodes in the chest. So our goal during the procedure is to provide both a diagnosis and stage in one single procedure so that patients can have a plan moving forward for their new diagnosis.
Does the robotic aspect of it, it makes it more precise? Does it make it any easier on the patient in terms of, having to spend a night in the hospital?
Great question. We have found that it is safer. One of the main things that can happen in terms of complications associated with any type of lung biopsy is a collapsed lung, or what's called a pneumothorax. Traditional bronchoscopy had a risk of collapsed lung somewhere on the order of 10%, and other types of biopsies done with a needle by radiologists could be as high as 20 to 25% chance of a collapsed lung. But with the new robotic technology, the risk is only about 1 to 2%. So it is a much safer procedure, and the vast majority of patients can go home the same day, a few hours after their procedure.
Talk a little, if you would, about the advances on the treatment side. In addition to just the advantage of catching it early, what else has changed?
Well, a lot has changed with lung cancer over the past decade. Some of it has to do with, as you mentioned, the early diagnosis. Now, early diagnosis patients that have, for instance, stage 1 disease are treated primarily with either surgery or radiation, and there have been advancements in both surgery and radiation. In addition, though, even patients that have more advanced lung cancer can benefit from a number of new treatment options, such as immunotherapy. And these have completely changed the landscape in terms of the prognosis, even for patients that don't have the benefit of being diagnosed early.
I know one of the other things you're working on is trying to narrow the racial disparities in care and outcomes that we see nationally. What's your approach to that?
It is true. Studies have shown that, for instance, African American patients do have a lower chance of being diagnosed with early stage disease nationally. And that's just an observation that's been made. Fortunately, at our center, when we've looked at this recently, some early data do suggest that we actually have about a 50% chance of diagnosing African American patients with stage 1 lung cancer at our center, which is much higher than the national average and is higher than their Caucasian counterparts at our center.
And that brings us back to screening and the availability of screening, the cost and insurance coverage. For a lot of people, this will be covered.
True. And we should probably just briefly mention the basic criteria for getting screened. You have to have a history of smoking, and specifically, you have to have what's called at least 20 pack year history. So pack year refers to the number of packs per day multiplied by the number of years that you've smoked. And patients have to have at least a 20 pack year smoking history. They can't have quit more than 15 years ago, and they have to be between the ages of 50 and 80. Now, you were asking about the insurance coverage, and the vast majority of patients that meet those criteria will be covered, both by private insurers as well as Medicare and Medicaid when applicable.
Are there other reasons other than smoking history that would predispose somebody to lung cancer and make a screening procedure, a CT scan, a logical thing to do?
Well, yes, this is a real challenge for us and will be a challenge moving into the future. We do know that somewhere on the range of 10 to 20% of patients with lung cancer have never smoked a cigarette or don't have a significant history of smoking. Unfortunately, at present, these patients do not qualify for lung cancer screening. So this is a significant gap that will need to be addressed in the future. And we're hoping that research will be able to better identify these patients so that we can do tests, for instance, non-invasive blood tests that may help us identify which non-smokers may be at risk and may benefit. But at the moment, they don't qualify for screening. And there are other factors, as you mentioned, in addition to smoking. One of those is actually argon gas, or radon, rather, which is something that is found certainly in the Maryland area and it is associated with cracks in the earth. It's required when you, for instance, buy a new house to have your basement inspected and for the radon levels to be measured.
So that's something you would advise people to keep an eye on. And if somebody watching this is a smoker, or friends with a smoker, and they probably tried to quit, what would your thoughts for them be?
Yeah, well, there are a lot of resources available, and patients should definitely not be afraid to talk to their healthcare providers about this. Uh, Certainly, there are a number of medications that can help patients reduce their cravings that they have. There are also local support groups. I know that we have smoking cessation classes at our medical center that patients can sign up for, where they can actually attend these classes and meet with others that have similar struggles, which can be very helpful. And even free resources like 1-800-QUIT-NOW is always a helpful thing to inform patients about. Sometimes they can get free nicotine patches as well as counseling through such resources.
Peter Olivieri at the University of Maryland, Baltimore, Washington Medical Center. Doctor, thank you so much.
My pleasure. Thanks for having me.